In the United States, as I've mentioned before, FLORA data has a large impact on how we practice treating EGFR-mutant non-small cell lung cancer. This is the first head-to-head trial of third generation versus a first generation EGFR TKI that has the highest progression-free survival, much better tolerability, and CNS activity. The Archer 1050 study is the dacomitinib versus gefitinib studies. That trial excluded patients with CNS metastases, so it's hard to judge what is the contribution or efficacy of dacomitinib in patients with CNS activity. Also importantly, dacomitinib at 45 milligrams per meter, 35 milligrams once a day, which is the approved dose. The patients require 60% of the patients require dose reduction, and I think additional 20% of these patients require 2-dose reduction. So tolerability, it's an issue with dacomitinib, and so if you just do a cross-trial comparison of Archer 1050 and FLORA, osimertinib is better tolerated. Osimertinib has a longer progression-free survival, even including patients who have enrolling patients who have brain metastases. So I think it's hard to, the outside real-world data is hard to supplant the data of FLORA study, in my opinion. The afatinib trial, the observation study, enroll patients either first, second, or third-line treatment, so a little bit more heterogeneous population. They do report more of the side effects profile. Efficacy, I think, is similar to what has been reported, so numerically it's less than what can be achieved with osimertinib. And it's a personal preference. If they want to sequence, and afatinib is a possibility followed by osimertinib, or clinician can use upfront osimertinib.